want to thank everyone for joining us. The first slide here, this is just an infographic from the Verne website about the cover study. I thought I would leave that up here and that we're going to dive into much more detail today. So these are the topics that I'm hoping to discuss today. I want this again to be a bit of a discussion here today. We do have a small group, so feel free to unmute and chime in. On the bottom of each of these slides, I have the Verne website where you'll find all the cover study information and the email address to contact Verne directly to get more information about participating. So, if you are watching this recording later on and you do want to send questions or learn any more about the study, these are really the best places to go to first. So I want to thank everyone for joining and thank everyone for listening. But first, I do want to just take a pause. I know everyone is very, very busy. Coronaviruses and this whole pandemic has really turned people upside down. And the participation in this cover study is sometimes seen as just one more thing that you're asked to do. So I do want to acknowledge that, and I do want to recognize, as I've been talking to people, that there are a lot of competing interests. There are a lot of other research studies to participate in. And so I thank you for watching this video to learn more about this specific project. I hope it speaks to you. I hope you feel that this answers a question that you are interested in. If it does not, if it seems like this is too much work, there are many other wonderful projects to work on. So this is not the only thing out there. This is here for information for you to decide for yourself. And I do, encourage anyone in the group that if you're dealing with things, personal things at home or clinical things, that it's okay, to say no to this project if at the end we really haven't given a good cause for participation. But I am going to be spending the next few minutes though trying to engage you and trying to get you to participate, and I hope you find value in what we talk about. So today on the call, I'm going to be leading the conversation. I have about 20 slides here put together for you, but I'm really just speaking about our initial experience here. And this is by no means the be-all, end-all of how to participate, but I am lucky to have with me also Dr. Shalhoub from the United Kingdom. He is here in his Friday evening, spending it with us, and he is a part of Verne, and he is a part of an institution that has been recruiting patients and inputting that data. And so I'm glad to have his level of experience here with us. And so I'll have him introduce himself and how he's been involved with Verne so far. So thanks, Dr. Shalhoub, for joining me.
Thank you very much for having me. And I've been involved with Verne since its inception, since I was a trainee. And I've continued my involvement since I've become a specialist or a consultant, or as attending, as you call them in the US. The collaborative model is very well developed in the United Kingdom and has been very productive.
I'm going to start with the why. Just in general, I think that the COVID-19 has impacted us all. And honestly, although this may be a once in a lifetime experience, I think right now this is still just the beginning. I think there's still a time where we're going to really see the impact of the economics of this pandemic. We don't have a vaccine in place. And so I think we still have yet to see, the full caseload of COVID-19. So this may just be the beginning, although we're hoping it's the ending. Our patients in vascular are a vulnerable set of patients. And so I think that they're affected by the disease of COVID-19, but also severely impacted by the economic implications and the impacts on our health systems and the strain on our health systems. So I think it's really important for us to understand that. Existing data sets are limited to address this question. In the United States, we use a lot of administrative data sets, which is based on coding and claims data, which I think will be woefully inadequate to understand the nuances of managing these patients and their coronavirus. And even our clinical data sets, I think, unless we add some new variables quickly to those, also won't be collecting that data and be able to give us the answers that we need. Single institution experience, I think, will give us a lot of details about how specific institutions are managing it, but I think that the generalizability to the broad vascular patient as a whole will be, again, difficult. And so we have a study like this that is hopefully a little bit of work for a lot of people that will span across multiple institutions, give us very unique answers to a very unique question. And I would argue that if you are interested in what this study is asking and the answers from this study, I would encourage you to participate in this study, because the only way that this study will truly be able to answer these questions is if we get wide participation and a large number of centers giving just a little bit, which I think is difficult to do in the current academic climate. I hope that's enough to at least engage you in the rest of listening to this webinar, if not, further participating in this study. I'll start with a brief overview. Some of you might be familiar with the protocol, some not, so this will hopefully just give a good baseline for everyone on the call to start with. So first, I want to just introduce the Verne team. So we've met one, Dr. Shalhoub is here with us here, but there's a great team that I've been communicating with, and they're accessible through that email address at the bottom right. I think that's the best way and the most efficient way to get through that. That's an email address that's monitored. So any questions that you have, it's good to email there, and then one of these team will reach out to you and help you to support getting things up and running. It's a team of UK fellows or registrars, as they're called there, and then as they moved on to being consultants or attendings. And it really is driven, I think, by that trainee initiative to get studies up and running. And it's a good collaborative model, and it's something that I think is an example for a lot of other groups to work off of. So I'm excited to start using that model here in the US. So for the color study protocol, it's broken into 3 tiers. I'll go over this just briefly. Tier 1 is the survey of practice. Tier 2 is a 3-month operative cohort of patients. And then Tier 3 is a 1-month urgent cohort. For the question earlier about what that Tier 1 survey is, it's an online survey monkey. The link is on the Verne website. It's essentially asking about what services you're still providing, what indications you're using to operate on. And it's supposed to be on the division level, basically saying, what changes on a division level have you made to your practice? And it doesn't necessarily go into, okay, this specific patient, how did you manage them and things like that. It takes about 5-10 minutes to complete. And the goal is really that as things change in your practice, to recomplete the survey, to get kind of a timeline of what services you're still offering, what's your capacity and things like that. And I think in the US, we're starting to scale things back up. And so while this is initially a measure of how we reduced our practices, it was a move to then how we are going to scale back up on our practices. So Tier 2 is an operative cohort. It's a 3-month survey of capturing the patients that we operate on, maybe how long they were then delayed for their surgery, what surgery we ended up doing, what surgery we may have done, or when we would have operated if we weren't in this coronavirus time. And then Tier 3 is then urgent consults. We get over a 1-month period, what decisions we made, how we managed those diseases, and then how that might have deviated from what we would have done in more of a standard time. So that's just a brief summary of these 3 tiers. And I'm going to speak, so Tier 1 really is just a survey that's filled online. There's been data entry that's already been ongoing with that. But really the big lift is in Tier 2 and Tier 3, where you need to have local approval in order to recruit and consent these patients, things like that. So we're going to focus more on Tier 2 and Tier 3 for the rest of this conversation. So again, this is Tier 3. We'll go into this a little bit more, but this is a nice infographic for Tier 3. I think it was the hardest for me to wrap my head around. These are patients that come from multiple referral sources, either outpatient, inpatient. It does take a little bit of work to really identify all these patients. You record patient information locally, and then you submit their clinical follow-up into the online REDCap database. So the current status for Tier 2 and Tier 3, these are the numbers out of the UK as of this morning. There's 23 centers that have input patients for Tier 2 and so far. In Australia, there's 3 with up to 7 soon. There's 4 centers in Greece, 3 in Italy and Libya, 2 centers from Singapore, Hong Kong, and Malaysia. And then there's 1 center in a number of different countries. And then pending, we actually haven't submitted any cases yet from the US. We have recruited and consented some patients, but actually haven't submitted any yet. And then in Germany as well. So this is kind of the current state of the study. So it's, a few centers, but a pretty wide spread across the world. And the goal is that in the next month or so, to try to get as many other centers up and running now that we do have this initial experience and initial input. And another question that's come up also is just the authorship guidelines. So I think it is important that when you're getting into a project like this and you're looking, okay, I'm going to be putting in a decent amount of time into this project, what am I going to be getting out of it? So not only answering a nice question, but also getting some publications. And so these are the guidelines on the Verne website as to how they develop their model. And they've published some papers already before, so you can see some examples of this. But the goal is really that each publication that comes out of it has a single corporate authorship policy, and that on some of the studies they can list individual authors, but with each paper is submitted an appendix that identifies how each person or each institution contributed, whether it was just patient recruitment and data entry, or whether they also contributed for data analysis, study design, or writing. And so really the key thing here, and that's something that excites me about a model like this, is that if all you did was you recruited patients and submitted it in, you're still counted on the publications, and you're still, you're attributed for that input that you give. Unfortunately, in a lot of research studies and a lot of collaborations, the people who are on the ground doing the consenting and doing the data input don't always get on that author line for the publication, which I think can be frustrating for a lot of trainees. And so with this study, if you put in a lot of work and you contribute at multiple levels, that's how you'll get listed in the appendix and as a part of this study. If you only have time to recruit some patients and input a little bit of data, you'll still receive credit for that work. So I think I just wanted to get that out in front, because that's actually something that I think is really cool about a study like this and this specific collaborative model. Any additions from Dr. Shalhoub on that? Did I miss anything?
Some people be wondering what the NRC is. The NRC is the National Research Collaborative. And so there's so many collaborative movements across the UK, both surgical and non-surgical, predominantly surgical. But there is a National Research Collaborative group which brings together all of these research collaboratives and makes kind of joint policies. For example, this authorship policy, which has been adopted widely across the collaborative movement, and therefore this really sets out how it is done and really ensures that everyone who contributes is recognized for their contribution. The contribution doesn't sit with the collaborative group executive. It's for the people on the ground. And to give you an example, we've already produced the first paper from Tier 1, and that's already been distributed to all of the authors and all the contributors. And the author for that was the Vascular and Endovascular Research Collaborative. There was a single headline author, and all of the contributors were listed in an extensive appendix, so everyone was recognized.
So now let's dive into, okay, if maybe we've caught your attention, we're now going to dive into the nitty-gritty, the specifics of how we really get this up and running. I'm going to talk about my personal experience at Columbia and Cornell. I'm a fellow here, first-year fellow. I've done some projects like this, but I've never participated in quite a collaborative like this. So I'm going to be speaking from someone who's coming at this with not a ton of experience. And I think what's great about this project is that's what this is speaking to, and that's who this is trying to engage, is that common denominator of someone who wants to answer a cool question, who wants to participate in research, maybe doesn't have a ton of experience, but wants to really dive in. And so this resource, in addition to a lot of other resources, are really there for that person to do it. So I'll be speaking. That's pretty much what the rest of it is gonna entail, is maybe some of my mistakes that I made so far and what we can do to help you not make those same mistakes. So the first thing is that I'm going to describe my team. Again, this is going to be speaking mostly about my experience at Columbia and Cornell, which hopefully should reflect maybe what you might be able to develop at your institution. But again, I'm going to be speaking from my experience, and this is going to be mostly saying what I've done and what we have, not necessarily what you should do and should have per se. So at each site, so where I'm at Columbia and Cornell in New York City, so probably two of the largest major academic centers in one of the worst hit cities in the world. And so we have a lot of research going on for coronavirus at both Cornell and Columbia. And this is one of many, many studies going on. And so it's important to make sure you have a good team to put this together. We have a fellow at each site who is essentially the site lead and is in leading patient recruitment while they're on surface. We kind of rotate between the two hospitals. We have a medical student on our team. We were early to engage a medical student. They're helping with consenting and data entry and design and helping with a lot of the workings of the study, which we actually haven't quite got up and running, but will be as a vital part as we move forward with the project. We do engage a study coordinator at both sites. We have a number of research coordinators within our division of vascular surgery, which is a nice support that we have and a great resource that maybe a lot of institutions and smaller groups may not have, but they were vital for our IRB submissions and organizing our documentation and really making sure that we're crossing our T's and dotting our I's related to consenting and things like that. So I'll hopefully share some of what I've learned from them here as well. And then we do have an attending surgeon. This is, overseeing all of this, and they're helping with our local design and engaging our local IRB and teams, and then also helping with patient recruitment. But that's just really the team of implementation. I presented this at division meetings, at our research meetings. Everyone in our division is on the IRB and is participating. This is really just that small cohort that is the driving force behind the project, but we really engaged everyone in the division. Everyone is behind it. Everyone is supporting it, and everyone is first and foremost aware of it, which I think is also very important to have. The next is resources, local resources. So you're going to need access to the cover study REDCap, which is free and basically just means that you need to submit. And once you essentially have your IRB, then you can submit in cases, but you do need a computer with an internet access in order to be able to do that. You need, what's been helpful for us is having a local secure online data repository. So this is some server or some website component that's in our local institution that is on a secure, HIPAA secure website, whether it's a folder on a shared drive, whether it's a SharePoint folder, whether it's a box. A lot of institutions have some sort of local place where you can store HIPAA information, and it's important to have that locally in addition to then this REDCap that is through the Verne team, because you're going to need to store identifying patient information locally that you're not going to then upload into the cover study. So it's important to have that as a separate IT infrastructure, which most institutions should have, but may require a little bit of work. We are doing written consents, so you do need a printer, you need a stapler, you need a folder to store some stuff locally and in a locked cabinet. But again, that's our local research group is helping with that, to manage that, because there is a little bit of paperwork to manage. It's important to have a telephone for calling patients. Our medical student and I, we use Doximity. This is a great resource in the US in order to call patients regularly, but not from your own cell phone. We actually have it. You can call then patients and then have their caller ID come up as actually the research phone number, so that then they can call back your research office or your clinical office instead of your cell phone. This allows for a much more pragmatic approach to contacting patients, getting consent, and getting information later is to have that addition. And again, it's free for any physician in the US. You need access to the electronic health record, and then you need just a little bit of time. So Dr. Shalhoub, anything else in regards to getting a team together or resources that you've engaged in the UK?
No, I think the real carrot is being part of the team. So there's lots and lots of volunteers, of people that want to be involved. And we've demonstrated that there is a big drive to get these cases submitted, because at the moment there have been already 746 cases submitted into tier 2, and that's enough to produce for us to start getting together the first manuscript for tier 2, the first of what will be a number of manuscripts. So in terms of resources, there's also the possibility of using research nurses. So there's a research nurse group in the UK, and I'm not sure if you have access to research nurses in the United States that would be able to help with recruitment and the like.
So the next is the IRB application. So as you're getting this team together, you should also be organizing your IRB application, because really you shouldn't be recruiting patients or consenting patients or submitting any data or storing any data without the appropriate ethical approval. And I think it is important to engage your local IRB. Our IRB right now is flooded with COVID studies. They are prioritizing them, but they are doing some specific reviews, because I do think it is important that right now institutions are wary of just doing a carte blanche approval of data sharing and things like that. So there is some scrutiny on the institutional side, and I think we should be aware of that. And also, while it might add a little bit more red tape, I think at the end the aim is to protect our patients. So the details about our IRB application, it did take about a month or so at our institution, but I think that was because of me putting together that application and trying to understand how the UK protocol applied to our institution. I am happy to freely share our IRB application, and hopefully should be able to replicate that at your local institutions to be able to expedite that a little bit quicker. This is an expedited application. It does not require a full review by the IRB board because it is a low-risk study. It's strictly observational. There's no intervention. There is, as a part of that IRB application, there is a written consent form and an information sheet. The Verne has a standard one. Our institution required a modification of it for our specific institution to have our own, institutional letterhead and things like that. Another important component is relevant translation. So if you have a Spanish-speaking population or things like that, our IRB is requiring that we submit certified translations for the information sheet. The Verne Collaborative does have a Spanish translation, which is probably the most common additional language that we interface with. But unfortunately, that is a limitation of the study and can be resource intensive to get all those translations, all depending on how your local institution addresses that. So that's a little bit of a hiccup, but majority of our patients are English speaking. And so we're still able to engage a number of patients while we work out all those translations. We applied for, and I'll go into this a little bit more later, about a waiver of documentation for consent in specific situations. And so we had to submit a verbal consent script and then some follow-up scripts for the additional follow-up phone calls, because this is a study where you not only collect data up front, but it's a year follow-up. I'm sorry I didn't address that earlier in the protocol, which is really why our local institution, the UK ethical boards, really did put on the stipulation for having a written or a verbal consent from the patient, because some of these patients, because of their disease process, we may clinically not be following up with them at 6 months or a year. And so with this study, if someone's in this study, we really want to have that 6 month and 1 year follow-up. And so this will require an outreach to the patient and a phone call. And so it really is important to consent the patient for participation in this study before then calling them at 6 months and 12 months. And I think that really is maybe something that sets this study apart, is that 12-month follow-up, because that's going to answer a lot of questions about these natural process of these diseases that we can't get from just a single audit over their time in the hospital. And so while that's, I think, the greatest strength of this study is getting that 1 year follow-up, and it's going to really answer the question, it's going to cause a little bit more of a logistical headache in that, you have to set up these scripts, you have to have a framework for calling the patients, you have to put it together, a written consent. But I really think that that's an important and a vital part of this study moving forward. And so the goal is that we'll give you these resources to make it as easy as possible to jump over those hurdles and to participate and get that data and submit it as easily as possible. The next one is the data use agreement. So this overlaps a little bit with the IRB application. It's technically separate from the IRB application in that IRB requires a data use agreement to be submitted, but it kind of runs in parallel. You can be IRB approved, but you can, that doesn't necessarily mean you can share the information outside of your institution. It just means that this is an ethical study. The data use agreement is an agreement between your institution and the group in the UK that you can share data that health information that the institution owns, you can share it with this other organization. It's more of a business agreement, if anything else. So the data use agreement is really important. And right now they're working on drafting that so that should be stock and available for you. And so that's been a little bit of what's been holding us up, is really getting that data use agreement outlined. And so I had a meeting actually with our local group. They're looking at these with much more scrutiny. And there's a couple specific things that I think are related to this study that I think it's important to understand, is that although we may aim to make this a de-identified data set, when in talking with some of the groups related to our data use agreement, technically this is a limited data set, in that by the fact of us studying the coronavirus and this specific time period of the pandemic, you assign a date to this study, and you assign a date range that is pretty narrow, and therefore it's not truly de-identified. Truly de-identified means that there's no date more defined than a year associated with that patient. And because it's in this time period, technically this is a limited data set and not a de-identified data set. And so they won't sign any data use agreements that have de-identified in the text. They'll still agree with it. They think it's important, but I think we should just recognize when we talk to the patients that this is technically a limited data set and not a de-identified data set. And then also they want to make sure that there's clear limitations for future use, that this data is only going to be used for this research study and that we're not getting paid for it. We're not going to sell this data. We're not going to, by recruiting more patients, we're not going to get paid more. They really want to make sure that there's no conflicts there, because a lot of people are trying to make money off the coronavirus and the pandemic and all of this stuff. And I think, we have very noble intentions with this study. And so I think we need to make sure that's reflected in our data use agreement, which it is. And so once they see that and that data use agreement is there, I don't expect we'll have any issues with signing of that data use agreement. But as of yet, we actually haven't had ours signed yet, and we're still currently in review. But hopefully that'll be out soon and available to you so that you can get that up and running and signed quickly. So Dr. Shalhoub, do you have anything else in addition about the ethical approval from the UK?
So in the UK, we're lucky that the system is a national system for research ethics approval. So once Verne had gone through the process of national research ethics approval, the groups were then had that IRB in place so that each centre could then apply locally to then get started through their research and development departments in each individual hospital. A couple of important points is that what we've recently done is an amendment so that we can consent patients retrospectively into tier 2. And what that means is that initially we were planning to recruit patients prior to them having interventions. And what this amendment has allowed us to do is recruit patients who've had surgery within the time period, even if we couldn't recruit them prior to their operation. So patients who've had surgery, we can go back and consent them post-operatively, and also patients that have been discharged, if we're able to contact them, we can then consent them retrospectively to have their data and their outcomes entered into the database. So there are a few things to consider when you're producing your IRB. Another important thing that Verne has done is in the UK, there's a distinction between audit and research. And a lot of the collaborative work has been done under the auspices of audit. And by deciding to go for research, this has allowed us to be in line with how the processes are done internationally, so that when we're producing manuscripts, it's very clear that the same kind of levels of ethical considerations have been taken both in the UK and outside, and also that it will allow us to have the longer term follow-up, which would not have been possible so much with the audit pathway. So we think that this is the right way to have gone. It's a little bit more work, but this will be a much more powerful study as a result.
Now we'll go over into the patient recruitment. So we're now through our IRB process. We are IRB approved at one site, and we're in the final stages of IRB approval at the other site. And so at one of our sites, we have started with patient recruitment. And this is now when I may be talking a little bit less and be transitioning over to Dr. Shalhoub a little bit more, that he can speak to this. But I will give a brief summary of our experience here in the US for patient recruitment. So what I've done for patient recruitment is, so again, the tier 2 is a 3-month review of procedures that were performed during the coronavirus pandemic. And again, to Dr. Shalhoub's point, I think it's important to recognize that, we can now do this retrospectively. So I think it's important to think about when your institution was most affected. Honestly, our operative volume has been very low. So up until now, we really haven't been doing that many cases. And so I think that the real value in our institution will be capturing the cases that now, as we're reopening and rescaling up our clinical resources so that we're doing procedures, but so is everyone else. And so there's more conflict, there's more delay. The patients are actually now coming forward a little bit more. And so we're actually starting to really kind of increase our clinical volume. At your institution, locally, it might be a little bit different. And so I think it's important to have that flexibility of really setting that 3-month or that 1-month time period to really capture those patients that would be most affected by the kind of coronavirus pandemic, and that when you're actually seeing them and getting these consults and doing these procedures. So now that we're recruiting patients, I do a weekly list review. I basically look at the operating room schedule of our cases. I look at our inpatient consults, our daily sign-outs, et cetera, our outpatient schedule, the new patients, and our inpatient list. And I look through if they meet the tier 2 and tier 3 criteria. And what I would encourage is that you look over, I'm not going to go over it too much here today, but basically For the tier 2, I'm looking for any patient who received a revascularization, or for the fellows, any case that you're logging in your logbook. We're not doing any just superficial wound debridements. We're not doing dialysis access. I think that's a big thing that this study is not including dialysis. I do think that's a valuable question, but again, it's just not what this study is looking at. It's mostly diseases for lower extremity occlusive disease, aortic aneurysms, carotids. It really is focusing on those index vascular procedures and amputations as well. For the consults, it's consults for vascular disease, those consults where, okay, they're presenting with an urgent disease process, acute limb ischemia, aortic syndrome, aortic rupture, acute stroke that needs a carotid intervention, these things that really do require timely management. And so it does require a little bit of looking at what the consult's for, if it's for something that is relevant. If it's, hey, can you just check out this patient and see if they have pulses, and you go and they have palpable pulses, you maybe don't have to include that patient in the study. So it's important to know the inclusion and exclusion criteria when looking at that. But it is pretty broad. But we've been looking at, and as I did this for our first week, we had about 7 or 8 patients that were included between tier 2 and tier 3. And again, like I'm saying, we're just starting to ramp up. Patients are just starting to come back into the hospital, really present with these consults. So we're busy all day, but at the end of the day, our index operations and our urgent consults where we have to make decisions that might be affected by the coronavirus pandemic, the target and in the protocol is 1 to 5 patients per tier per week. And we're hitting that. We're actually probably going to be at the higher end of that, probably about 10 patients a week, I think, once we're up and our volume is up. And it really takes the whole team to kind of look at all of these lists. I'm able to do it in an hour or so, but it's, I think, important for everyone to be aware so that they have a patient that they think is appropriate, they can kind of pass that along.
We will be picking up the dialysis access patients now. We're going to change the pro formas to ensure that they're included. And another thing which just to highlight is that we're including both COVID positive and COVID negative patients, just because people may think that this is just going to be for COVID positive patients. Is for both COVID positive and COVID negatives. For one, particularly with tier 2, to look at the outcomes that these vulnerable vascular patients have following and with coronavirus, which we believe to be quite poor given what's come out from the literature, but also to look at how the environment, the situation, the pathways, the PPE, all of the other changes have globally impacted on the outcomes for those patients having surgery, even if they don't actually have the coronavirus themselves. So we're picking up both the corona positive and coronavirus negative patients.
And so how many patients are you recruiting at your center per week?
We're picking up about 10 patients a week and putting them in for tier 2. And a similar number, probably for the tier 3, it's a large number. The number of referrals that come through the center is quite large. And so there'll be a large number of patients entered in tier 3, maybe up to 40 a week.
Yeah, we're not quite at that point yet. And then it's once you've recruited or essentially identified a patient that's appropriate for your study, what will be important is to track we have a local Excel file on a secure SharePoint that all team members can access. And essentially, once I've identified, or any of our team members have identified this patient, that patient goes on, I put their name, their MRN, their gender and ethnicity. That's important for our IRB reporting, their preferred language to help with communication, their consult and operation date, the consent information sheet, and then a phone number and their email address. And this just gets everyone all on the same page because, some of the consenting and the data entry then transitions over to other team members. So this is basically, as I review these lists, I'm putting this information into our secure data sheet. And it's really important to have that on a HIPAA-compliant shared data server. On your own personal computer or on a Google Docs is not appropriate because this is patient identifiable information, and we want to make sure this is secure and doesn't get lost somewhere. So I think that's really critical. But most institutions should have something available for you, and I think that's something to engage in and set up early on.
Yeah, we have a shared drive on our hospital network, which the data stored on that means that all of the teams that are collaborating and all of the individuals that are collaborating on the project can access it and update the information in real time.
So again, so for the tier 3, which is maybe the more difficult to kind of wrap your head around, for the referral sources, we're at this state. So this is, for understanding these urgent consults, this is looking at the clinics, this is looking at the ER, the patients that come through the ER, the inpatient consults, anything that's reviewed in your multidisciplinary teams, and then recording that data locally. That's what I was talking about, getting a secure database for follow-up. This is an Excel file. And then what's important is then once you create that file in REDCap, it's going to give you a de-identified record ID. You plug that into your Excel file so that then now you can map your local identifiable information to that limited data set that's now in the cloud and on the Verne website. And so, but before you get any of that information and submit it, you have to go through the consenting process. So I wanted to talk, I've now consented on a number of patients for the trial. It's not a lot, but I'll just give you some of my initial reactions to it. Consenting patients for research, if anyone's had to do it, I've had to do it for a couple other studies. It can be time consuming in that there is some paperwork. Our consent form is 5 pages because it's really the patient information sheet and the consent form. And written consent, it can be time consuming, and in a time that we're strapped for time, it's something that you'd really have to invest in. I've really enjoyed some of my initial conversations with patients. I actually do think it gives a platform to talk about how the coronavirus is impacting their care and is impacting them and the care that we're able to provide to them, and gives a platform to say, hey, I'm sorry, we have a number of patients that are just waiting for the procedures, and while they're waiting, I talk to them and I say, I'm very sorry that we're having to delay your case again because we don't have OR time. But, we're actually participating in this study right now to understand how this is going to impact your care. It doesn't require anything additional from you, but we are going to be sharing your information with an international registry. And I've had some patients, who are reluctant to share their information outside the institution. And I think it's important to respect that for them. But some patients really respond to that. And I think they really appreciate that we're looking into this and that we're addressing this and we're addressing their concerns. And it gives just a few more minutes for us to talk to them and engage with them about their disease and maybe how they're dealing with this stressful time right now. So I've actually enjoyed that time that I've put into it. I haven't necessarily enjoyed then copying the consent and bringing it back to the patient and then storing it in the file and making sure we cross all the right signatures and all that paperwork. But that time is minimal, and really probably the biggest time investment is sitting down and talking with the patients, which I have actually enjoyed. But again, I think that is a time commitment that we have to be willing to make by participating in this study. One component of this is that it's best practice that we get written consent and we put that down, but this is a pragmatic study as well. And so we've added, and our IRB was on board and supported us with getting a waiver of documentation for consent in specific situations. So specifically in the settings of contact restrictions where patients have coronavirus and you don't want them to be coughing and then grabbing a pen and this paperwork, and now you're like, I just brought this paperwork out of a room that I had to be in full gown for. That's a patient that you can waive the documentation of consent and just say, we have verbal consent. This was the conversation that we had. The patient consented to participation, and we're going to put that in our documentation. And IRB has been fully supportive of that model for those patients. So we can still have the conversation, we can still fulfill the ethical obligations, but then we don't have to be bogged down with that paperwork of bringing that into the room. A lot of our workforce is remote. Our medical students are working from home and not from in the hospital. And our research nurses and things like that are working from home. And so they can then just call up patients and get consent, but then they waiver the documentation of consent and they just say it was given over the phone. If the patient was discharged before we could get around to them, or in one situation, a patient had hand ischemia, as a part of their vascular patient. So really it was inappropriate to ask them to try to sign a piece of paper. And so, there's a lot of nuances, and because this is a pragmatic study, and the goal is, I think, to have that conversation about the study and the fact that we're going to be calling them later, and not necessarily that we have to have everything signed and dotted, because this is a low risk study, and the DHHS has actually put out a lot of guidelines for more pragmatic consenting workflows for low risk studies. It's important to engage those workflows at your local institution. So Dr. Shalhoub, did you have anything to add in that area?
Nothing really. In general, most of the patients are very grateful for the efforts that we're taking to get some information about what's going on, particularly when we're quite busy with other matters relating to the coronavirus anyway.
And then the last thing is the data entry and the patient follow-up. This is one where I personally, we don't have our data use agreement set up, so we have not input any data yet. And then the patient follow-up will be at 1 month, 6 months, and 12 months. So that's going to be to the future. So this is really then planning, okay, for now that next step. And so it's important to remember that the complete case report form is, the goal is to have that put together by discharge. But again, this is a pragmatic trial. So it's there is some flexibility for when those case reports should be put in. But the goal is that this is done real time. One, so that you can, really make sure you keep up with the flow of patients, but then also to engage the patients and call them to clarify anything, because there are some specific things in that case report form that may not be in the chart. Then there's follow-up at 1, 6 months, and 12 months. We plan to first review the chart to see if they followed up and see if we have documentation of any of this at those time points. And then if not, we have a script that we've created, and we are happy to distribute that is based on those outcomes that we're going to be calling for at 6 and 12 months. I expect that the case report forms may change by then, and we plan to just submit an update and addendum to our IRB. But our IRB did want a draft of those scripts at the time of submission, which we've created that for you and are happy to share. So that kind of got that through a little bit quicker. And then, but I do think it is important to really try to get the data in quickly, because some of these questions are about, okay, what did you do? And then what would you have done if there weren't these clinical restrictions based on coronavirus? Which, if you're reviewing a chart from 3 months ago, a clinician and the surgeon may not remember exactly what their thought process was and may not exactly remember the time course. And so I think it really is important to try to get this data in and analyze it and review this data in real time prospectively. And that's why this is important, I think, to do in a prospective manner, get the consent, engage for the follow-up, because I think that's how we'll really be able to get that nuance of the documentation and the data about what we did, and then how that differs than maybe what we would have done if we didn't have these external restrictions. And we're working at our institution as we go through this data collection process to develop some smart tools, smart phrases to help people document it more quickly, so that we can really streamline that documentation and data collection. Anything, Dr. Shalhoub, from actually submitting cases that you could add?
It's absolutely good practice to enter the data as contemporaneously as you can. It will mean that the data is much more accurate. It will mean that you won't get this build-up of data that you then need to enter later on, which can be quite burdensome. It's, if you enter it quite regularly, the task is quite light, but if it builds up, it can become quite cumbersome. So I would recommend that you enter it as contemporaneously as you can. Another thing is we're kind of reviewing the data on a very regular basis. And so as I mentioned, the first tier 1 paper has already been written and has been sent out to the authors and is going to be submitted. The first tier 2 paper we're in the process of putting together, and the first 800 or so cases will go into that. So it's important that your data is in there, so you are included in that tranche of the literature, because I think there's a duty for us to get this information out as quickly as possible so people are aware of it and then can act on it. And so there will be early and late publications for each of the tiers. So there'll be a number of outputs from each of the different tiers of the cover study.
And then how long, just so people can understand the time input, how long does it take each of your team members to review maybe one patient and input their case report form?
About 10 to 15 minutes, because we have an electronic medical record, so a lot of the information is there. And if you have a case report form that you print out and you can take to the patient, if there's any questions that pertain to their medical history that's not available on the electronic medical record, then at the time that you consent the patient, you can also ask them the questions as well.
Yeah, and so I think it's important to we're doing a lot of our work remotely. So, while we're filling it out, we're encouraging our research team to reach out to patients to clarify things that we might miss, but then also reaching out to the clinical team that if maybe there's information that we think there might be in clinical decision-making or that the clinical team might know, is to engage them as well.
That's particularly important for tier 3, because that's the tier that talks a lot about what made you change your decision. Why did you decide to do this rather than this? Did the risk of patient contracting coronavirus mean that you didn't admit them when you otherwise would have admitted them? Did you try to do a more minimally invasive treatment than a more robust, perhaps open operation that you would have otherwise done to reduce their hospital stay and therefore their overall exposure and risk to COVID? There's lots of nuances there that are important to pick up in tier 3, which will then be kind of grouped into themes for analysis.
Well, thank you so much, everyone, for joining us. I don't have any more prepared content, but I'm happy to address any additional questions that anyone might have.
Thank you for all the information. That's really great, and it's actually very interesting. I guess like one question I had, is there any way we can sort of get a copy of the IRB that we could sort of utilize for our IRB?
Yes, I will. I've shared it with pretty much all of the emails that I have, but I'll work with the Verne team to get it posted to the website. We've just now approved for a week or so, so it's a fresh document, and I wanted to wait till it was approved to publish, but we will be freely sharing that. So yeah, we'll make that available.
The UK ethics documents are all available online on the website on the bottom of the screen, and we'll of course share Dr. Johnson's US IRB as soon as he releases it to us.
Thank you very much.
I think another aspect that is important to consider is that people think that this may only be relevant or generalizable during the COVID pandemic. It's not only that, it will tell us about the outcomes of patients who've got coronavirus and those who are having interventions during the COVID pandemic. But it's also, as Dr. Johnson said, a fantastic opportunity to look at the natural history of conditions where there are established treatment pathways. And by being forced to change those treatment pathways, we then get to the opportunity to follow up patients who've had a treatment pathway which is different from what we normally do and see how that impacts on the outcome. So it allows us to answer much wider questions about very kind of traditional vascular pathology. What happens to aortas that you don't operate on? What happens to carotids that you don't operate on, whether they be symptomatic or asymptomatic? So, this is a golden opportunity for us to answer some questions which people have been trying to get solid and more robust answers to, but the time wasn't really right, and there was a lot of inertia about finding the answers or doing the research. But now this is an opportunity to get the answers to some of those questions, and there's huge amounts of interest in that.
Yeah, thank you for the talk and clarifying information about the data use agreement. Is there a particular point person on the Verne side of things that my institution can be in touch with once we have that completed and ready to share?
Dr. Ruth Benson,
Yes.
Who's the head of Verne, has been my point contact. What I would recommend is emailing the cover email at the bottom, and I can share that contact, just to get her information, and she will connect. But I will say, so they're in the works of creating a generic data use agreement, because it might be a little unwieldy. It would be a good problem to have if there were too many institutions trying to all manage their own data use agreements across all the different institutions and things like that. And our institutions have been open to receiving and kind of signing a standard data use agreement with the University of Birmingham. So she will be, hopefully it will be ready very, very soon. And then essentially all you have to do is then you just bring that data use agreement to your institution. And I think once we get a couple institutions signed and reviewed, it should expedite that process for everyone else. But again, this is still early in the process, so we thank you for being on the call. And that's something that I think the specific details have yet to be hashed out, but that will be distributed once that is available.
Understood. Thanks very much, Dr. Johnson, Dr. Shalhoub.
My pleasure. We're hoping to see some more US institutions on the list of collaborating sites, and it'd be great to get the number of sites up to over 100. And hopefully we'll be soon talking about patients in the thousands rather than the hundreds.
All right. Well, if there aren't any questions, I'll let everyone enjoy the rest of their Friday. I'll let Dr. Shalhoub get back to his Friday evening, and everyone enjoy the rest of your weekend. Thank you very much for your time.
Thank you very much. Have a good evening, everyone. Thank you.